You'd assume a pharmacy makes its money the way a store makes money. Buy a product, mark it up, sell it for more than it cost. That's how it works for the toothpaste and shampoo near the front door. It is not how it works for the counter in the back. The one with the actual medicine. The one the whole building exists for. On a striking number of prescriptions, the pharmacy is paid less than what the drug costs to acquire. Not a thin profit. A loss. And the company setting that price isn't the pharmacy, isn't the drug manufacturer, and isn't even the insurance company you're picturing. It's a business most people have never heard of, sitting quietly between all of them. That business is called a pharmacy benefit manager, usually shortened to PBM. Think of it as a broker whose entire job is standing between the insurance plan and the pharmacy, negotiating what gets paid, what gets covered, and which drugs make it onto the list a patient's plan will actually reimburse. When you hand over your insurance card at the counter, the price you pay and the amount your pharmacy receives back aren't decided at that register. They were decided months earlier, in a contract you'll never see, by a company you've never dealt with directly. Here's the detail that reframes everything. 3 of these companies handle the overwhelming majority of the country's prescriptions. Together, they process about 80% of all prescription claims in the United States. That's a level of concentration you'd expect in an industry with a handful of visible household names, not one operating almost entirely behind the scenes. And it gets stranger. Those 3 PBMs aren't independent referees sitting neutrally between insurers and pharmacies. Each one is owned by a health insurance conglomerate. CVS Health owns both a PBM and one of the country's largest health insurers. Cigna owns a PBM. United Health Group owns a PBM. The company negotiating drug prices on behalf of an insurance plan is frequently owned by that exact insurance plan's parent company. Picture hiring a real estate agent to negotiate the price of a house, only to learn the agent works for the seller. That's roughly the structure here, except it plays out across a market worth several $100 billion a year. So how does a PBM actually make money? This is where the industry becomes deliberately hard to see clearly, and that difficulty is not an accident. A recent academic analysis modeled a single hypothetical drug priced at $360 and showed something remarkable. Depending purely on which accounting method the PBM chose to report, its profit margin on that one transaction could appear as low as 10% or as high as 87%. Same drug, same transaction, same company. The only thing that changed was which flows of money the PBM decided to count as revenue versus which flows it decided to simply pass through without reporting. A margin that looks unremarkable on paper can be hiding a margin that would look shocking if reported differently. This matters because PBMs have spent years pointing to their reported profit margins historically in the 4 to 7% range as proof they aren't the reason drug prices are high. But a margin is only meaningful if you know what's being measured. If a large share of the money flowing through the deal never even shows up on the books as revenue, a low percentage doesn't mean low profit. It means the profit moved somewhere the analysis can't easily see. One of the places it moves is rebates. Drug manufacturers pay PBMs rebates in exchange for favorable placement on the list of covered medications. In 2025 alone, the total value of these rebates and discounts on brand-name drugs reached $416 billion. That's not a typo-sized number to skim past. That's larger than the GDP of most countries. Flowing through rebate negotiations most patients will never see referenced anywhere on their receipt. Now here's the part that should make you ask a different question. If PBMs are capturing that much value through rebates and accounting flexibility, what happens to the pharmacy actually standing at the counter, filling the prescription, and absorbing the wholesale costs of the drug before insurance ever reimburses it? The answer is the squeeze. Because PBMs also set the reimbursement rate, the amount a pharmacy gets paid back for dispensing a given drug, and that rate is negotiated in the same contracts where PBMs are simultaneously collecting rebates from manufacturers. Pharmacies have reported being reimbursed below their own acquisition cost for certain medications, meaning they lose money on the exact transaction the patient thinks is the pharmacy's core business. A pharmacist can fill a prescription, follow every rule correctly, serve the patient exactly as intended, and still come out behind on that single sale. One loss on one prescription doesn't sink a pharmacy, but multiply that across thousands of prescriptions a month, year after year, and you get a slow financial bleed that no amount of candy aisle markup can offset. This is where the chain reaction begins. Squeezed reimbursement rates reduce the margin pharmacies earn on their core product. Reduced margin puts pressure on the front of the store, the snacks, greeting cards, and seasonal aisles to cover losses the pharmacy counter itself is generating. When front-of-store retail sales soften too, as they have with inflation-conscious consumers pulling back on discretionary spending, there's no remaining cushion left. Locations that can't absorb both pressures start closing. Store closures concentrate remaining prescription volume into fewer locations, sometimes creating what the industry now calls pharmacy deserts, geographic areas with no nearby pharmacy at all. Enclosures tend to hit some communities harder than others. Pharmacies in majority Black and Latino neighborhoods have closed at higher rates than those in majority white neighborhoods, turning a financial structure problem into an access problem for the people least able to absorb it. To see this chain reaction played out at full scale, look at what happened to two of the most recognizable names in American retail pharmacy. Rite Aid went through bankruptcy and by late 2025 had completed a total liquidation. The company simply ceased to exist as an operating retailer. Walgreens admitted its underlying business model was non-sustainable, announced massive store closures, and was eventually purchased by a private equity firm, ending its run as a public company. Under new ownership, the closures accelerated. None of this was primarily a story about people no longer needing prescriptions. Demand for medication didn't collapse. What collapsed was the economics of dispensing it. Executives and analysts pointed specifically to reimbursement rates from PBMs squeezing pharmacy margins as a central driver. For decades, the assumption was that the pharmacy counter existed to drive foot traffic into a profitable retail store. But as pharmacy reimbursement kept shrinking, the relationship quietly reversed. The front-of-store retail business had become the only thing keeping a money-losing pharmacy counter open. That reversal explains why closing a store often makes more financial sense than keeping it running, even when the pharmacy counter is still busy filling prescriptions every day. A busy pharmacy can still be a losing location. So where does this leave the industry going forward? In the more optimistic scenario, growing scrutiny from Congress and the FTC forces meaningful reform, reimbursement models that separate the cost of the drug from the service of dispensing it, and greater transparency around rebate flows. In the more difficult scenario, the same forces continue unchecked. More independent and chain pharmacies close. More neighborhoods lose their nearest pharmacy. And the reforms that do pass arrive too late for the companies already gone. The simple assumption that a pharmacy chain makes its money selling medicine at a markup was never the full picture. Today, it is a company trapped between a price for its core product often set below cost and a retail environment expected to quietly cover the difference. The medicine on the shelf was never really the profit center. The real economics of the business live one layer up inside contracts between PBMs and manufacturers that most patients, and increasingly most pharmacists, never get to see. The pharmacy chain isn't in the business of selling drugs. It's in the business of surviving a price it doesn't get to negotiate.